All right, for this lecture, we will cover vasculitis and related entities. So what is vasculitis? Vasculitis is inflammation and necrosis of blood vessels, and it's typically categorized by the vessel size involved. Now, you can have mixed vessel vasculitis, and we will point areas in which that is most commonly seen. So starting out with classifications. First, we think about small vessel vasculitis. This typically involves inflammation of the arterioles, capillaries, and postcapillary venules located in the superficial and mid-dermis. So usually the higher up you go in the skin towards the epidermis, the smaller the caliber of vessels that you have. Medium vessel vasculitis typically involves small arteries and veins, and this is located more in the deep dermis and subcutis. And this is important because if you want to rule out a medium vessel vasculitis, you're going to be needing to get usually a wedge excision specimen, or else you're not going to be able to see the medium vessel vasculitis, and the pathologist is not going to be able to rule it out or rule it in for you. And large vessel vasculitis, this is typically involving larger arteries in the aorta. Now, what is the cause of vasculitis? And as a clinician, as well as a dermatopathologist, I often remind our trainees that, we can recognize it's vasculitis, but unfortunately, approximately half the time, we're never going to really truly be able to establish cause and effect. And that's because many of the patients that get vasculitis have a lot of different risk factors. They could have had a recent infection, a recent medication change. They could have a malignancy. They could have an inflammatory condition all at once. And so to really establish exactly what caused the vasculitis is nearly impossible. And so we have to kind of raise the white flag a bit and say, you know what, I think it could be this, it could be that, and kind of statistically rank the most likely. But sometimes patients get it and there's really no other comorbidity to really establish or blame, and that's idiopathic. So recognizing it as vasculitis can help, and that can help get you towards a cause, but just understand that it's not always going to be possible to say. So after idiopathic, we have infection, inflammatory disease, medications, and malignancy, approximately in that rank order. So if somebody has a recent infection, nothing else changed, that's probably the cause. If the patient has inflammatory disease, and that's a broad term, so it could encompass things like autoimmune, it could encompass various other inflammatory rheumatoid diseases, et cetera, then if that flared and they got a vasculitis, you can think that that could have been the cause. A recent change in medication and nothing else changed, then you would highly suspect that that would be the cause of the vasculitis. And of course, a new onset malignancy with nothing else changing, that could also be a cause. And why? Why are these processes all able to lead to vasculitis? Because vasculitis at the end of the day is an inflammatory pattern. And so you can get to the end result of vasculitis from many different mechanisms, just the same way you can get to the end result of something in life through many different pathways. So I like to, tell my trainees that if you see a car wreck on the road, it's a car wreck, but establishing exactly what led to that car wreck, whether it was an impaired driver, whether it was another driver's fault that left the scene, whether it was a car mechanical malfunction. There's so many different reasons that you could see the end result of a car wreck. And so same thing with vasculitis. Just establishing vasculitis is the first step. I always kind of laugh at these drug exposure charts, because the reality is that unfortunately you can get so many different inflammatory reaction patterns with drugs. But for example, there are some that are more common to cause vasculitis than others. And I have here a list of many different medications that people take all the time and do not get vasculitis. So there's no clear 100% expectation that patients being on these medications would cause vasculitis. However, in a minority of patients, there can be an induction of vasculitis after starting the medication. And what I say is that taking a very careful drug history and trying to establish what was new, what was not, that's going to be the only way to get to the answer. And it many times will just be nearly impossible to truly figure it out, because there have been so many medication changes. trialing reduction of medication can help. And it's going to have to probably be a 1-by-1, or just getting rid of all non-essential medicines to try to see if that alleviates the vasculitis. So getting back to that question, how does this happen? How do you get the end result of vasculitis? So you can have immune complex mediated mechanisms. And what happens is you have an immunologic trigger. And so that makes sense that infection, inflammatory disease, medications, or malignancy could all result in that first immunologic trigger. What happens after that is an antibody generation, and that leads to immune complex formation. The immune complexes, the antigen antibody complexes, can deposit on the blood vessel walls. And that deposition is allowing for complement activation to be triggered. What you have is generation of complement-derived factors such as C3a, C5a, and that leads to polymorphonuclear recruitment. Polymorphonuclear is another name for neutrophils. So when you see neutrophilic inflammation around vessels, you start to think, could you have an immune complex mediated mechanism of vasculitis? The neutrophils come in, they degranulate, they release inflammatory mediators such as collagenase, elastase. Those enzymes help break apart all of the structural components of the extracellular matrix. That leads to vessel wall necrosis, thrombosis, occlusion, and hemorrhage. And so you can see that there are many different steps here in vasculitis. And depending on when you biopsy the vasculitis, is it early? Is it at the peak? Is it later? Is it an old vasculitis? You may be seeing different evolution of the process. So if you biopsy super early vasculitis, you may not see great necrosis of the vessel wall. You may not see a ton of extravasated red blood cells. If you biopsy it right at the peak, you may be seeing a good amount of fibrinoid necrosis developing in the walls with surrounding extracellular erythrocyte extravasation. And if you biopsy it too late, what you might see is a great lack of vessel integrity, and you may not be able to see a lot of open lumen. You may see more of hemorrhage. You may see diffuse vessel wall necrosis and thrombosis, and a ton of extracellular material from the red blood cell. So understanding that it's a very temporal process, and depending on when you biopsy it, that can make the difference in what you see. So typically, it's probably best to biopsy probably in the middle part of the vasculitis process. What would you expect to see, though, if you biopsied early vasculitis? So what's the pathogenesis? So the pathogenesis of early vasculitis is going to be that you start to have the antigen antibody immune complexes forming, binding to that circular antigen. The circulating antigen allows for the immune complex formation to start depositing in the lumen of the vessels, and you have mast cell degeneration, which leads to increased vascular permeability. So in the early phases, that immune complex deposition on the blood vessel walls with subsequent activation of the complement leads to the beginning of the inflammatory cascades and the mast cell recruitment. In the peak of the process, what you're going to have is complement-derived factors coming in, such as C3a and C5a, which lead to the actual neutrophil chemotaxis. So neutrophils start coming in both from the inside and the outside. You have neutrophil degranulation, which results in inflammatory mediators, collagenase, and elastase. All of that together starts to lead to the vessel wall necrosis, the thrombosis, the occlusion, and the hemorrhage. So biopsying in between the middle to late part of the evolution is going to give you those more classic findings, which we will show. But keep in mind that I'd say about 24 to 48 hours is usually your optimal. Some people believe that 24 hours is the peak. It just depends on the specific evolution and pathophysiology of the patient and what caused it. But lesional biopsy of a pretty fresh, 1-day-old lesion should get you a pretty good answer. And of course, you can do serial biopsies as well if the patient and the clinician agree to such. You can also have ANCA-mediated vasculitis. So what happens is you have activation of the neutrophils by specific cytokines. That cytokine-based activation of neutrophils leads to expression of intracellular proteins such as PR3 and NPO on the surface of the neutrophil. Then what happens is the ANCA antibodies binding to the antigen on the polymorphonuclear cells or the neutrophils. That leads to the neutrophil adherence to the endothelium and release of reactive oxygen species, pro-inflammatory mediators, and chemoattractants, which ultimately lead to vessel damage and further neutrophil recruitment. So just in contrast, compared to the immune complex mediated, with the ANCA mediated, what you have is an actual expression of antigens on the surface of the neutrophil, okay? So here you have expression of, in the green circle, it would represent PR3. That's an antigen on the surface. Or MPO, the red circle, represents an antigen on the surface of a neutrophil. These kind of purplish protrusions here are adhesion molecules. So what happens is the ANCA-mediated antibodies bind to those antigens on the neutrophil. This creates an activation state, leading to production of reactive oxygen species and chemoattractants. This allows the neutrophil to directly recruit more neutrophils and directly lead to vessel wall destruction. And there's this temporal pattern to this. So early on, you're going to see that cytokine priming. In the middle part, you're going to have those circulating ANCA antibodies bind. And in the late part, that's where you're going to get the vessel damage. So when we talk about ANCA associated, we typically think of microscopic polyangiitis, granulomatosis with polyangiitis, and granulomatosis with polyangiitis, and eosinophils. The second one that I mentioned, granulomatosis with polyangiitis, or GPA, used to be known as Wegener's, and the granulomatosis with polyangiitis and eosinophils, that's known as Scherg-Strauss. So you may hear both of those names as well. Usually the anti-PR3 antibodies are associated with the ANCA-mediated granulomatosis with polyangiitis. That's typically a C-ANCA-mediated process. And usually in granulomatosis with polyangiitis and eosinophilia or Scherg-Strauss, more of the ANCA-mediated antibodies are P-ANCA antibodies, and those target MPO. Statistically, that's the most likely, but you can have mixes and matches. That's why we often get both ANCA antibodies, C-ANCA and P-ANCA, and the titers as well. We get the PR3 titer and the MPO titer to try to get an understanding of, is this an ANCA-mediated vasculitis or not? So what are the clinical features? The clinical features include very small palpable purpura typically in small vessel vasculitis. So you can see on the picture that you have these small purple to red, dark red papules, and that's the palpable purpura. You can have urticarial papules. You can even have pustules, vesicles, petechiae, and targetoid lesions. And usually small vessel vasculitis favors dependent sites or areas of tight-fitting clothing due to stasis, hydrostatic pressure, and the underlying inflammatory process that's occurring. Medium vessel vasculitis, though, on the other hand, leads to other findings such as livida reticularis, retiform purpura, ulcers and necrosis, and subcutaneous nodules. And when you have a mixed vessel vasculitis, you have features of both. So it makes sense that if you're affecting a deeper vessel, that you could get results in a larger area of ischemia to the overlying skin, resulting in ulceration and necrosis. You may see leukocytoclastic vasculitis on a superficial biopsy, but it doesn't mean that there's not some deeper medium vessel vasculitis happening that you just missed on the biopsy. And so if you see clinical ulceration, if you see clinical nodules, If you see retiform purpura or livido reticularis, but you only have LCV on the biopsy, then you should suspect that there could be a deeper median vessel vasculitis and try to get a deeper biopsy to try to find median vessel vasculitis, or just correlate clinically to say that the clinical findings suggest that there's probably some underlying median vessel vasculitis occurring. And that's where the clinical correlation becomes absolutely essential, because you may be able to even diagnose median vessel vasculitis in other ways as well. So what's the typical time course? The typical time course after 7 to 10 days of that trigger is when you typically get the vasculitis. So this makes it difficult because someone may get a vasculitis and they did something, the day before, and they may think that that was the cause. That's not typically when the trigger happens. The trigger happens further away from that. So 7 to 10 days. So you may not actually be able to go back with the patient's clinical history and figure out exactly what happened a week or more than a week, 1 to 2 weeks before that. And sometimes with drug-induced processes, it may be even longer. And so it's going to be really difficult to identify the trigger. But it kind of goes to show you that the trigger takes a while to actually result in the buildup of the antibodies, whether it be immune complex mediated or ANCA. It's just going to take time to get those antibodies circulating to a pathogenic level. What happens is you'll get systemic symptoms that include fever, weight loss, musculoskeletal pain, neurologic symptoms leading to paresthesias, renal involvement leading to hematuria or renal dysfunction, pulmonary involvement leading to hemoptysis. Keep in mind, in some conditions, systemic symptoms may precede skin involvement, on average 6 months to years. So again, this is crazy to think that in some types of vasculitides, the patient may have systemic symptoms and that's all they have. They don't have the skin involvement for up to half a year to a year in some of these entities. So this is what makes rheumatology, dermatology overlap very challenging, but also very complex and interesting, very intellectually stimulating set of diseases. And to be able to utilize your serologic data, your clinical data, your histopathologic data, the entire clinical scenario to come up with a diagnosis. If you can get to that point, then it's extremely rewarding. In most cases, immunosuppression is going to make a huge difference because this is antibody mediated. So if you suppress either antibody production via rituximab or you suppress overall immune system function with steroids, you usually get a nice clinical response, despite not always knowing exactly what the trigger was. This is a nice reminder of the types of workup you might want to do if you're suspecting an etiology that's leading to vasculitis. So think about infectious. You want to rule out bacterial, viral causes, upper respiratory infections, hepatitis. Typically, hepatitis C is more commonly associated with vasculitides compared to hepatitis B and A. So you'll want to get an ASO to rule out, strep. You'll want to get a hepatitis panel. Liver function tests when you're thinking about hepatitis leading to vasculitis. Inflammatory processes such as rheumatoid arthritis, lupus, Sjogren's, these can all lead to vasculitis. As we mentioned, you'll want to get an ESR, a CRP, an ANA, rheumatoid factor, anti-CCP to fully investigate. For malignancy, you'll want to make sure that the patient doesn't have a plasma cell dyscrasia or a myeloproliferative disorder. So you'll want to get your CBC with diff as well as a SPEP and UPEP. Chest x-rays can always be helpful to identify if there's any type of lymphoma or hilar lymphadenopathy or pulmonary masses. Getting imaging is going to be very important to rule out whole body malignancy. Drugs Of course, drug history is absolutely key. You want to look for a CBC that has maybe more eosinophilia, but I will say drug-induced anything does not require eosinophils. So you can have a drug culprit causing pathology and not have eosinophilia. ANCA associated, so you'll want to think about your microscopic polyangiitis, your Schurd-Strauss, granulomatosis with polyangiitis. And that's where you'll want to get your C-ANCA and your P-ANCAs. And then immunoglobulin associated. So things like Henoch-Schönlein purpura, type 2 and 3 cryoglobulinemia, urticarial vasculitis. These are usually thought to be IgG associated or immunoglobulin associated. And you'll want to get a UA. You'll want to get blood chemistries, including creatinine, to assess for renal function. Serum cryoglobulins such as C3, C4, total complement. So you'll want to at least order separately cryoglobulins and then complement panel as well. How do you work this up from a practical standpoint? So you'll want to get a skin biopsy for H&E and DIF. And in contrast to autoimmune bullous disease, you want to go lesional. You want to go lesional here for your H&E and your direct immunofluorescence. Some people say less than 48 hours old is required. It just depends, but optimal is going to be 24 to 48 hours. But once you start getting over 48 hours, you're going to start to see less distinct activity defining your classic path features. And so that's why we say 24. Now you can get a DIF lesional as well because you want to look for immunoglobulin deposition in the vessel or in the vessels itself. So that's where the vasculitis is happening. So what are the treatment objectives here? The agents that we care about are those that suppress the cells and pathways involved in vasculitis, as we expect. So B cells, you can even have T cells supporting this, but B cells are the ones that are making the antibody. But oftentimes B cells and T cells work together for the final production of antibodies via B cell stimulation by T cell cytokines. And then neutrophil function as well. So you can see B cell function. Of course, we always think about rituximab, the anti-CD20, to target B cells. You can have IVIG, which kind of just directly competes with the circulating immune cells, and of course plasma pheresis. So think about actually taking the problematic antibody out of the circulation. B cell and T cell targeting medication. So prednisone just is a very broad actor, as well as azathioprine, Cellcept or mycophenolate mofetil, alkylating agents such as cyclophosphamide, chlorambucil, and methotrexate. So these all are a more broad interfering set of agents that impair both B and T cell function. And then on the right side here, we have a list of larger amounts of medicines that directly act on neutrophil function as well, not exclusively, but do impact neutrophil function. So prednisone, again, tetracyclines, and this is kind of why I think doxycycline does very well in treating folliculitis and acne, because you have a lot of neutrophilic inflammation. Dapsone's another one of my favorites when we're talking about targeting anything that's a neutrophil-based pathology. There's been evidence for Plaquenil and indomethacin, thalidomide, biologics, and mTOR inhibitors as well, in terms of acting on neutrophils. But this shows we have a lot of things in our toolbox here to try to combat vasculitis. And the goal of the treatment is really to suppress or even reset the immune system. So patients don't always have to be on these medications forever. If we can calm down the vicious positive cycle that's happening, the positive feed-forward mechanism of the out-of-control vasculitis, if we can just stop that long enough to get their immune system to kind of reset, for lack of a better term, then we can try to wean these patients off over time. Sometimes, and most of the time, depending on the etiology, if it's just a quick drug-induced LCV, you're not going to need lifelong treatment. However, if it's something like an ANCA-mediated vasculitis, they're going to be on treatment for quite some time, if not forever. So a little bit more about vasculitis classification. Histologic features in most forms of vasculitis are not specific for an entity necessarily. When we want to kind of get to the definition of vasculitis, we have to put together the clinical history, the histology, and the serologic data. And when we're talking about the histology, we need to decide what is the type of inflammation, the type of the vessel involved, and the size of the vessel involved. If we can get that information, we're really going to be able to get closer to the diagnosis. There are classifications of vasculitis, and this is typically through the American College of Rheumatology or Chapel Hill criteria, which incorporates histologic features. So an example of a Chapel Hill consensus conference classification, you can think about large size vessel vasculitides like giant cell arteritis, which involve the temporal artery, and Takayasu's arteritis, which involves large muscular arteries. When people refer to medium-sized vessel vasculitis, the classic is polyarteritis nodosa. You can also have Kawasaki disease involving medium vessel vasculitis. And then with your small size, and that's where most of these entities live, you have your granulomatosis with polyangiitis and eosinophilic granulomatosis with polyangiitis. Now, these can be mixed size, mixed vessel, polymicroscopic vasculitis. So the first three here, you can definitely think about it being small and medium, but most likely what you'll see on biopsy are small vessels involved, depending on how deep you get. And interestingly, on biopsy, you may not see classic LCV. You may see something more of a palisading neutrophilic granulomatous dermatitis. So you may not actually even see the actual vasculitis. You may just see granulomatous inflammation, interestingly. Henoch-Schondlein purpura or IgA-mediated vasculitis, essential cryoglobulinemia-based vasculitis, and cutaneous leukocytoclastic angioitis, or LCV. Just another list kind of summarizing these entities here. I will say that in addition to large, medium, and small vessel vasculitis, you can have very unique forms of vasculitis that are more rare. You can have lymphocytic vasculitis. So often we focus so much on neutrophilic inflammation around the vessels, but sometimes you can have predominantly lymphocytes causing vessel damage or being associated with vessel damage. Occlusive vascular disease, so thrombosis, intraluminal clotting, and leading to vasculopathy. And you can have even non-inflammatory purpura. So mostly it's just vascular congestion and vessel destruction without much inflammation. So when people talk about vasculitis, oftentimes you can't avoid talking about vasculopathy because they go hand in hand. And in fact, if you've got an older vasculitis, you can see vasculopathy. If you've got a vasculopathy, an older vasculopathy, you can see vasculitis. So there's a lot of overlap, and you really have to go back to the clinical scenario and do laboratory workups to try to see if you can establish a cause of that vasculitis or vasculopathy. This is a very famous diagram that incorporates the diagnoses and where they are typically affecting the vessels. So as we mentioned, Takayasu arteritis, giant cell arteritis affects mainly the larger vessels such as the aorta and the arterial, the larger arteries. And once you start getting into the arterioles all the way to the capillaries, the venules, and the veins, that's where you're going to think about your ANCA-associated small vessel vasculitides, which are truly small and medium because it can incorporate the larger medium-sized vessels. Medium vessel vasculitis typically refers to the the vessels that have a little bit larger diameter, and that includes polyarteritis nodosa and Kawasaki's, as we mentioned. And when you think about the immune complex or small vessel vasculitis, such as IgA vasculitis, cryoglobulonemic vasculitis, or hypocomplementemic urticarial vasculitis, these sets of diseases actually have the smallest window, if you will, of which small vessels will be affected. So think about the ANCA associated being a lot more promiscuous. They can affect a higher range of variability in terms of the vessel size. And think of your large vessel vasculitis as only encompassing a couple of entities, and your purely medium vessel vasculitis only encompassing a couple of entities usually. And then your immune complex being a much more focused set. And then you can have anti-glomerular basement membrane disease. Usually that's just affecting the capillaries within the vessels itself. I mean, within the renal tissue itself. As we mentioned, leukocytoclastic vasculitis, the most common forms of vasculitis are just an umbrella term of leukocytoclastic vasculitis, because you have that reaction pattern. It's a vasculopathic reaction pattern. It's not a specific diagnosis. So people say, well, they have LCV. Clinically, they have palpable purpura, but on pathology, they have leukocytoclastic vasculitis. So when we say clinically it looks like LCV, what we're saying is that clinically it's palpable purpura. It looks like there's no blanching to the lesions, that there's extravasated cells, and that it probably correlates with a small vessel vasculitis. On histology, you're going to see leukocytoclastic vasculitis. Leukocytoclastic vasculitis is not considered specific diagnosis because, as we just mentioned, it can be due to many different causes. So people like to remember bugs, drugs, connective tissue disease, malignancy. Those can all lead to it, as we mentioned. Classically, you're going to find that palpable purpura with non-blanching papular erythematous lesions on the lower extremities. As we talked about, the outcome is variable, mostly with the benign course. So on the left side, if you see a patient like this, this is why oftentimes the clinician's so confident that they're dealing with LCV. You've got these deep, dark purple palpable papules and some actually big enough to be plaques. But most of them are pretty small in a deep purple to red color, non-blanching. Over here on the right side, you don't really see anything that's very specific here. And so there's a drastic difference between active vasculitis clinical appearance and maybe some post-inflammatory pigment alteration, which you might see on the right. As I said, you can even have targetoid lesions with LCV. You can have annular lesions. Sometimes you can have a bullous LCV, which is such a strong, robust reaction that you actually have an overlying detachment of the epidermis and necrosis of the epidermis. The pathogenesis we already talked about. The histology is kind of where the meat of the talk is. So you're going to see fibrinoid necrosis around the vessel walls. You're going to see infiltrating neutrophils, some areas of extravasated red blood cells. However, depending on when you biopsy it, so in this case, you don't have a ton of extravasated red blood cells. So this could be a little bit more right before you get an abundant amount of extravasated red blood cells, because you do see fibrinoid necrosis, you see karyorrhexis, leukocytoclasis on the outside. And I typically think of leukocytoclasis as small little nuclear fragments of what used to be a part of a neutrophil. So it's kind of like, it looks like the neutrophilic nucleus is just broken apart into small pieces. Many times you will have areas of intact endothelium, but it's difficult to find the lumen, as I say, because you're looking around and all you're really seeing is areas of extravasation and fibrinoid necrosis. And then you're looking to see, are there any more intact lumen here? If you've got vessel destruction, then it makes sense that you can have resulting closure of the vessel lumen. You can have an internal coagulation process happening in response to the damage. leading to small vessel thrombosis later on. So to summarize what we were looking at, we're looking at superficial vessels typically affected with neutrophilic infiltrate and karyarexis, expansion of the vessel wall with fibrin deposition, and erythrocyte extravasation. This is kind of another classic picture to show you the swirling around. Somebody's actually likened it to like if you were flushing a toilet of neutrophils and they're swirling around the circle of the lumen there. So it's this kind of very angiocentric neutrophilic inflammatory process. Depending on when you biopsy it, you may not see great fibrinoid necrosis. And so if you see a lot of neutrophils around the vessels and leukocytoclasis, but not yet a lot of impressive fibrinoid necrosis, then you could say an evolving vasculitis can't be entirely excluded, and maybe an additional biopsy at the peak of a new lesion. However, this is a much more convincing of fibrinoid necrosis. And this is just a great example of the extravasated red blood cells you can start to see, and that's what leads to your palpable purpura that you see in most cases of evolved leukocytoclastic vasculitis. So you definitely don't need a direct immunofluorescence, but if you're looking for a specific IgG, IgA that may be leading to it, then you're going to want to take a look at a DIF. And so what happens is that you'll get a perivascular pattern of fluorescence. Usually C3 and IgM are more strong in early lesions, whereas in mature lesions, IgG and fibrinogen are more likely to be seen. So here's an example of just that vascular pattern of fluorescence and lesional vasculitis. So if this were IgA, then you could say, well, this is an IgA vasculitis. If the patient has Henoch-Schönlein purpura or HSP, then you're going to have an IgA fluorescent signal that looks like this. Let's kind of back up a bit and review the histology of arteries and veins. So in basic histology, we learned about the structure of an artery versus a vein. So an artery is going to have a lot more muscle around it, longitudinal wreath-like muscularis, because of the higher pressure that the vessel has to undergo. So you'll have internal elastic membrane to allow the vessel to expand and contract with the pulsation of the blood pressure. And these are typically more round because they have more of a muscular structure integrity to it. Whereas with the veins, usually have more of a bundled muscular layer with no internal elastic membrane. And that makes sense because your veins are lower pressure and they are not going to need to deal with as much pulsating. You may or may not see valves depending on the section that was taken. And usually because of the lower pressure and the least amount of muscle there, you're going to have more of an oval shape on histology. It's more easy to compress the shape of it. But here you have a wreath-like muscularis of an artery with that internal elastic membrane. If you did a Verhoef Van Giesen stain, you'd be able to see that internal elastic membrane highlight quite nicely. Here is another example of a vein. So as opposed to the artery with the vein, you've got more of a bundled muscular layer, and the lumens compose a much thinner wall with endothelium. It's compressible. You can imagine it just doesn't have much pressure there. And you don't really see a great valve in this picture. Maybe up here to the top left, it was trying to form a valve of some sort, but it's hard to say. So for large vessel vasculitis, you want to think about entities such as giant cell arteritis. Typically, this occurs in patients greater than 50 years old with granulomatous inflammation. It affects the aorta and major branches, especially the extracranial branches of the carotid artery, temporal artery, 2 centimeters in length needed for examination. So that's a really big biopsy, right? So if you want to really establish giant cell arteritis or some of these larger vessel vasculitides, you have to think about getting deeper inflammatory structures or deeper structures that are undergoing inflammation. So you're not always going to see that granulomatous inflammation, but what you're going to absolutely need is that larger caliber vessel to be able to make the diagnosis. Takayasu arteritis. This typically involves patients less than 50 years of age. You have granulomatous inflammation, and the aorta and the major branches are usually affected. We often think about polymyalgia rheumatica as being associated with large vessel vasculitis, specifically giant cell arteritis. So here is an example of a clinical image of temporal arteritis. You can see this ulceration around the temporal region. Again, due to the inflammation of the temporal artery and giant cell arteritis. Here you can see a large caliber vessel with a lot of neutrophilic and granulomatous inflammation composed of giant cells. It's disrupting even the wreath layer of the muscle here. Just a higher view to look at those giant cells. And here's an example of Takayasu arteritis with the inflammation around this large vessel here. You can see the large artery structure and then this very nice concentric inflammatory rim. Higher power shows some scattered giant cells within the inflammatory infiltrate. You can see the elastic membrane as well. So to touch upon medium vessel vasculitis with polyarteritis nodosa and Kawasaki disease, starting off with polyarteritis nodosa, it's known as a necrotizing inflammatory process of medium-sized or small arteries without glomerulonephritis or vasculitis in the arterioles, capillaries, and venules. Often involves the branch point of the vessels. The neutrophilic inflammation leads to granulomas and ultimately to vessel destruction. Fat necrosis can be seen in this entity, and the associations are typically hepatitis B, libido reticularis, and cutaneous ulcerations, and mononeuritis multiplex. Kawasaki's disease is an arteritis involving large to medium-sized and small arteries and associated with mucocutaneous lymph node syndrome. Coronary arteries are often involved. Aorta and veins may also be involved in 25% of cases. This usually occurs in children. For your clinical lectures, you're going to get a lot more information than this. It's just for the purposes of DermPath, it's more about organizing the caliber, size vessel on pathology and what you would see. So you can see many times you can have vasculitis involving digits and kind of this ischemic digit presentation when the medium and particularly medium-sized vessels are affected. You get ischemia to the skin. So you can see this is a good example here of if you were to do a punch biopsy in an area that did not include this vessel, you would have missed it. So if you do a deep enough biopsy, in many cases an excision, like a wedge excision, you might be able to get down far enough to be able to get that vessel. It's possible to get fat on the biopsy, just a normal punch biopsy. However, to really increase the surface area and the volume of capture, it's smarter to do more of a larger biopsy. So you could try to go with like a 1 centimeter punch biopsy or just a wedge excision into the area that you suspect is involved. And this is your classic polyarteritis nodosa, neutrophilic inflammation, destructing a medium-sized vessel. And you'll often find those medium-sized vessels at the bottom of the dermis right before the subcutaneous or right above the subcutaneous junction. So thrombophlebitis obliterans or Berger disease is an example of medium vessel vasculitis as well. So this is an example of a medium vessel undergoing complete neutrophilic destruction. You can see diffuse necrosis as well around medium-sized vessels. And if it's a very advanced stage, then all you're going to see is necrosis. And so keep in mind that if you biopsy a necrotic area, that's what you're going to see is necrosis. You may not see any architecture whatsoever that's going to give you a hint of what was there before. And so biopsying an area that's not completely necrosed to try to identify the median vessel vasculitis will be key, because if you're biopsying something that's black clinically, then you're probably just going to get diffuse eosinophilic necrosis on histology. So you may have heard of the big five. So many people will refer to entities as the big five because the vessels included are those bigger than the post-capillary venule, and the patients are often in bigger trouble. This is kind of a term that's developed by Dr. Elston. So what do we think about? We think about entities that involve a mix of vessel sizes. As I said, the post-capillary venule plus the larger, deeper vessels, where it's very common to have endothelial necrosis, and often you get ANCA associated issues, and you have an ANCA-mediated pathophysiology here. So of course, you would think about granulomatosis with polyangiitis, which is formerly Wegener's. Commonly, it's a C-ANCA-mediated process directed against anti-proteinase 3. You can have specifically anti-proteinase 3 titers that can be measured. And Scherg-Strauss, also known as granulomatosis with polyangiitis and eosinophilia. And that is commonly due to a P-ANCA directed against myeloperoxidase. So you can get the titers for myeloperoxidase, or MPO for short. And a microscopic polyangiitis, commonly P-ANCA as well as anti-MPO. However, with these entities, you can definitely have a mix of either, or it just depends on the clinical scenario. Septic vasculitis is another one of the big five, and rheumatoid vasculitis. We already talked about the ANCA patterns. So with eosinophilic granulomatosis with polyangiitis, it's typically P-ANCA, and that's Scherg-Strauss. Granulomatosis with polyangiitis, C-ANCA, and that's GPA, formerly known as Wegener's, and microscopic polyangiitis, P-ANCA. Typically, as I mentioned, the P-ANCA associated with MPO, C-ANCA associated with PR3. So you should know this very well by now, because I've repeated it multiple times in this lecture, and you're going to hear it over and over again in your training. So it's just important to think that these ANCA-mediated processes are really statistical. So predominantly seen in GPA, 90% of patients would have C-ANCA. Well, that means 10% of patients don't, right? And for P-ANCA, in microscopic polyangiitis and Scherg-Strauss, 60%. Well, that means 40% don't. They may have the other, or they may have nothing. And so just keep in mind that lab tests, in the same way that immunohistochemistry is a statistical probability, so are laboratory abnormalities. And you just really have to have a high degree of suspicion. That's why you get multiple pieces of data: clinical, histopathologic, serologic, the whole clinical scenario together to put together a picture of what's happening. And you may have something that's never been defined or reported in the literature before, something unique. So we really have to take these vasculitis cases on a case-by-case basis to understand what's going on. Now, if you look at the whole host of different possible diagnostic testing for patients with suspected ANCA-associated vasculitides, you can break it down based on what you think they have and what you think you should do to really work it up. So you can see that for all of these entities, you should definitely get a chest X-ray and or a chest CT scan, an electromyogram or nerve conduction studies, and a lung, nerve, or kidney biopsy in all of these entities. These are possible additional diagnostic tests, not absolutely required. And when you're starting to look at microscopic polyangiitis, you usually don't have to do further workup with respiratory tract or muscle biopsy or echocardiograms or CT scans of the sinuses. But when you're moving on into Wegener's granulomatosis or GPA or Scherg-Strauss, you're going to actually find that those are going to be pretty helpful. So you'll want to do an upper respiratory tract or muscle biopsy, potentially an EKG, CT scan of the sinuses for Wegener's or GPA, because it can affect the sinus tracts. The inflammation can really localize to those areas. With Scherg-Strauss, the serum IgE is going to be more relevant because, again, it's more associated with eosinophilia, and typically IgE and eosinophilia activity are elevated together. So you can see there's some overlap here, but there's also some exclusivity, and you don't have to do all of this to really make the diagnosis. In fact, if you've got classic clinical scenario, you have the right ANCA antibodies and the right antigen titers, and a biopsy showing vasculitis or even palisated neutrophilic granulomatous dermatitis, you can pretty much make the diagnosis. Now, there are different criteria you can use. So, of course, if you're trying to make the diagnosis of GPA, then C-ANCA positivity is going to be a strong supportive piece of data. But there's other clinical features that you'd want to look for. So mucocutaneous involvement, including oral ulcers and red friable gingiva with hyperplasia, also known as strawberry gums. You can have an upper respiratory tract involvement in most cases, up to 90% with epistaxis, mucosal ulceration, nasal septal perforation, saddle nose deformity, cough and hemoptysis, pleuritis, and dyspnea. Papulonecrotic lesions are often seen as well. These are painful subcutaneous nodules and ulcers resembling pyoderma gangrenosum. And I've had a case of a patient that was on cocaine, and everybody thought it was a levamisole-induced vasculopathy. In reality, she was heavily positive for C-ANCA. She had a nasal septal perforation that everyone was thinking was due to cocaine use. She also had strawberry gums, and she had all the classic presentation of Wegener's. It just happened to be that she was also abusing cocaine. And so it's possible that the cocaine could have induced a C-ANCA expression, and then that C-ANCA overexpression led to a Wegener's or a GPA type picture. So again, that goes back to thinking what was an identifiable trigger that happened, but it could have happened whether or not she was using cocaine that was could or could have not had levamisole. We don't know. So just interesting how real life cases can have a lot of overlap and diagnostic uncertainty. But at the end of the day, she had all these clinical criteria for GPA. She had a biopsy that showed granulomatous inflammation, not necessarily a classic LCD, but it was also biopsies of these pyoderma gangrenosum type areas where there were a ton of neutrophilic areas of inflammation. And of course, that's what you're going to see in a chronic papulonecrotic ulcer. So site of biopsy selection is also going to be super important, and you have to really correlate that clinically. Renal disease can be present in 20% of patients, seen in actually 20% of patients can have renal disease right at the presentation, but it's really common in most patients, up to 75%. They can have glomerulonephritis, obviously, with the renal disease. And don't forget about musculoskeletal involvement, ocular involvement, neurologic involvement, GI involvement, and cardiac involvement in this disease entity. You can see pyoderma gangrenosum-like ulcerations. You can see this kind of nail bed hemorrhage that's occurring. You can see some ulcerations even on the tongue and some other areas that look to be like classic LCV. This is that typical granulomatous vasculitis that you'd want to see, but you're not always going to see this. As I said, most biopsies, you're actually not going to see this. What you're really going to see most often is some type of leukocytoclastic vasculitis, and you're going to see palisated neutrophilic inflammation. Oftentimes, what you will definitely see if you biopsy an ulceration is just an ulcer with acute inflammation, abundant neutrophilic inflammation. So that's not going to be that specific. So you really have to select the biopsy site, and you may have to do several different biopsies, and you may have to actually get help from IR, interventional radiology, or surgeons to go into areas outside of the skin to get biopsies of other organs that may be involved. So a renal biopsy, a lung biopsy, these things may be more revealing than just a superficial skin biopsy. Here's another picture of the classic palisated neutrophilic and histiocytic giant cell granulomatous inflammation. So you can see this destruction of a vessel with a bunch of giant cells surrounding it. Again, this is not what you're going to see practically most commonly if you biopsy these patients, because you really have to find the right spot. You may just get sheets of neutrophils and you may not see any giant cells whatsoever. So the workup for granulomatosis with polyangiitis, as we talked about, definitely get your ANCAs, get ESR, CRP, CBC, chest X-ray or CT, looking for airway involvement, urinalysis, looking for renal, and plus or minus echo if you're wondering about cardiac involvement. Treatments are going to include things like systemic steroids, oral cyclophosphamide, anti-TNFs, rituximab. I will say that up-to-date lists that there was a head-to-head with cyclophosphamide and rituximab. And the clinical trials say that they're pretty comparable to each other. They both do a good job. So really, you just have to choose based on the side effect profile that you would want. And I would prefer to use rituximab in most cases. Staph aureus can be associated with disease relapse, and so there is some thought for a role for antibiotic treatment in patients, just to reduce the staph load and potentially reduce any triggering effect that bacteria can have on the disease process. Relatedly, Sturge-Strauss syndrome, or GPA with eosinophilia, that's the P-ANCA positive. And the way people can remember that is, you've got eosinophilia and you've got GPA. So that's kind of like a pair. You can remember P-ANCA. It's associated with asthma and peripheral eosinophilia. The triggers have been many things, but include things like vaccination, rapid discontinuation of corticosteroids, desensitization, and leukotriene inhibitors. The progression of Sturge-Strauss goes through 3 phases. So phase 1 is known as the prodromal phase. You have symptoms of allergic rhinitis and nasal polyps, and asthma may persist for years or even decades. Phase 2 is known as the eosinophilic stage. You've got peripheral eosinophilia with respiratory tract infection and GI symptoms. And phase 3 is the vasculitic phase, where you've got systemic necrotizing vasculitis with granulomatous inflammation, which may occur years or even decades after the initial symptoms. Here you can see what happens when you have a small to medium vasculitis. So you've got areas of nodules forming, ulcerations, and also classic palpable purpura. And this is what you'll often see in a mixed vessel, small, medium process such as Sturge-Strauss. Very similar histology with what we talked about with GPA, except you've got more abundant eosinophils. Here in this picture, this is a great example of the eosinophilic population that you would see. There appears to be actually quite a bit of lymphocytes in this example from Dr. Elston's textbook, but you have, you can see that there probably was a vessel here, and now the lumen is completely occluded and obliterated. Here you see a nice example of a palisading granulomatous inflammation around vessels, tons of eosinophils in there. So this would be very supportive of a diagnosis of Sturge-Strauss, if that's what the clinical impression was as well. And so just more examples of the vasculitis with abundant eosinophils. Systemic symptoms, as we mentioned, asthma is a big one, but neurologic symptoms, including mononeuritis multiplex. Unfortunately, cardiomyopathy and pericarditis, which can lead to death, necrotizing glomerulonephritis, pulmonary capillaritis leading to alveolar hemorrhage, musculoskeletal involvement, and GI tract involvement can occur. For this diagnosis, you're going to want to see eosinophilia. That's in the name of the diagnosis, so it's definitely helpful to see an eosinophilia level of greater than 10 to the 9th. With elevated IgE can also be supportive of the diagnosis. As I said, P-ANCA is positive in 55 to 60%, and this ANCA positivity is associated with a higher risk of cardiac involvement. The additional workup is similar to GPA. Treatment will involve corticosteroids, not surprisingly, But you can also target the eosinophil based pathology or the IgE pathology. So you can think about mepolizumab, which is an anti-IL-5. And so you're going to try to reduce the IL-5's activation of eosinophils. So targeting the IL-5 with mepolizumab should be helpful. Also, omalizumab can inhibit the binding of IgE to the Fc epsilon receptor. And microscopic polyangiitis, as I mentioned, is another small to medium vessel vasculitis. It's ANCA mediated. Typically, it's P-ANCA positive in 60%, but of course, it could be C-ANCA in some cases where you may not detect any ANCA positivity. Affects mid-aged to older males, and the pathology shows segmental necrotizing vasculitis, but usually don't see granuloma formation in this entity. You can have systemic involvement with all of the organs we've already talked about. So of course, renal, lung, neuro, and in 75% of patients, the skin disease develops after the systemic manifestation. So in many cases, the skin will be what brings the patient for the evaluation, and they've already had organ dysfunction caused by the disease. Treatments obviously will include corticosteroids as well as cyclophosphamide or rituximab, as we mentioned for GPA and EGPA. Persistence of ANCA despite the induction of remission is associated with the risk of relapse, not surprisingly, because if you've got more ANCA circulating despite treatment, then that's going to be associated with a high risk of relapse. Septic vasculitis is exactly what it sounds like. So you've got a vasculitis involving the mix of vessel sizes. It could be postcapillary venules plus larger, deeper vessels. And typically you have a thrombus with vessel necrosis, dirty necrosis with ample neutrophilic debris. So, typically in the setting of infection, you can actually have thrombi within the vessels, and then that surrounding neutrophilic inflammation. So small vessel vasculitis, as we mentioned, involves principally the post-capillary venules. That's a kind of a high yield question that you may be asked on an exam. The post-capillary venules are the most commonly targeted in small vessel vasculitis. Endothelial necrosis is rare. Typically, though, you'll see the fibrinoid necrosis on the outside of the vessel wall, and then later on, depending on the extent of the vasculitis, you'll actually lose the integrity of the vessel. Rarely, small vessel vasculitis, in terms of the pure small vessel vasculitis, is ANCA associated. Again, that doesn't count the fact that you can have both small and medium size in ANCA-mediated vessel disease. The most common causes include drug-induced connective tissue disease other than rheumatoid vasculitis, mixed cryoglobulin disease, serum sickness, and Henoch-Schönlein purpura. And this group of disorders is referred to as the little five by Dr. Elston because only the post-capillary venule is involved. Other small vessel vasculitis includes Henoch-Schönlein purpura and cryoglobulinemia. Henoch-Schönlein purpura, as one of the little five, involves IgA in the vessels on DIF. Typically, children, extensor involvement with large mottled patches of purpura involving the bone, joint, gut, and renal involvement. Palpable purpura with abdominal pain and joint pain in children below the waist is often associated with upper respiratory infections such as strep. And some, unfortunately, may have kidney involvement. This is more common in adults. Here's an example of Henoch-Schönlein purpura. And on pathology, you'll see this leukocytoclastic vasculitis type pattern with fibrinoid necrosis, just another example of that. And on DIF, you're going to find IgA around the vessels in a vascular pattern, lesional skin. You can find fibrinogen and complement as well. This is an example of a vasculitis from a patient with IgA vasculitis. And I got this in fellowship quite a bit. In fact, I believe I took this picture from one of the cases that we had in fellowship of IgA vasculitis. Cryoglobulinemia includes thrombosis. Typically in type 1, you're going to just have monoclonal immunoglobulin, and you're going to get this amorphous jelly-like formation within the vessels. And that's what you can see here in type 1 vasculopathy. And this is caused by just an overabundance of monoclonal antibody that basically causes vessel intraluminal coagulation, and you can see this red jelly in the vessels. The mixed types include 2 and 3, and you'll see both monoclonal and polyclonal, and that results in leukocytoclastic vasculitis. Mixed vessel vasculitis does include the type 2 and 3 cryoglobulinemia, as I mentioned, and it also includes ANCA, vasculitides, connective tissue associated vasculitides, and secondary causes, as well as infection and inflammatory disorders. Cryoglobulinemia appears as a vasculitis or a vasculopathy, depending on the clinical scenario. Again, think about the word cryo meaning cold. So in cold temperatures, the precipitate of the antibodies make a vasculopathy happen in type 1, and in type 2 and 3, you've got more of a vasculitis picture with a mixture of IgM and IgG polyclonal antibodies. So here's kind of the separation and how you can break this up into subtypes of cryoglobulinemia. So when someone says cryoglobulinemia, you can think about it causing a vasculopathy, which is type 1, or vasculitis, which is types 2 and 3. So in type 1 cryoglobulinemia, you have much more monoclonal IgM, so much more monoclonal IgM than the IgG. And the associations with type 1 cryoglobulinemia include plasma cell dyscrasias and lymphoproliferative disorders. Typically, you'll see vascular occlusion. And clinical manifestations are Raynaud's phenomenon, retiform purpura, gangrene, and acrocyanosis. So if you see those clinically, you're definitely going to want to include vasculopathy on your differential and think about a type 1 cryoglobulinemia. Types 2 and 3 cryoglobulinemia can usually cause a vasculitis. And so that's where you're going to get your palpable purpura, your arthralgias, peripheral neuropathy, and glomerulonephritis. In type 2, you'll usually have a monoclonal IgM, much more than IgG, and it's against polyclonal IgG. In type 3, you'll have polyclonal IgM against polyclonal IgG. So just a quick way to remember 1, 2, and 3, monoclonal IgM, and then 2 is monoclonal IgM against polyclonal IgG, and 3 is polyclonal IgM against polyclonal IgG. So always think about the IgM first, and it's either not against IgG, or it's against polyclonal IgG, or it's polyclonal against polyclonal IgG. Remember the associations with types 2 and 3 cryoglobulinemia. So hepatitis C, HIV, autoimmune connective tissue disease, and lymphoproliferative disorders can all be associated with types 2 and 3 cryoglobulinemia. Again, at the end of the day, if you're seeing clinical manifestations and you're not sure vasculitis or vasculopathy, you have to get cryoglobulins. That's why we always want to order that if the patient has any evidence of vasculopathy or vasculitis clinically. 90% have cutaneous involvement in types 2 and 3 cryoglobulinemia with palpable purpura, erythematous papules, dermal nodules. You can rarely have libido, necrosis, ulcerations, and bulla, but definitely still a possibility. Systemic involvement, including arthritis and arthralgias, peripheral neuropathy, GI disease, and hepatitis, as well as membranoproliferative disorders. Unusual forms of vasculitis include granuloma faciale, erythema elevatum diutinum, which I like to refer to as the easily forgotten vasculitis. Many people might think about erythema elevatum diutinum and forget that it's a vasculitis. You can also have incidental vasculitis, such as neutrophilic dermatoses like Sweets, urticarial vasculitis, and Wells syndrome. So incidental vasculitis means that you have vasculitis, but there was probably something much more pathologic happening, and then you just happen to have vasculitis. The other thing I will say at this point of the lecture is that if you have a chronic ulcer or an ulceration of the skin, you can find vasculitis within the dermis, and it may not have been the cause of the ulcer. It could just be a secondary effect of the neutrophilic and chronic inflammation coming in to heal the ulcer. So seeing vasculitis in the bed of an ulcer does not tell you anything about the pathophysiology of the ulcer itself. That's why doing biopsies on ulcers and expecting the pathologist to tell you what the cause of the ulcer was is pretty much, in most cases, impossible, because at the end of the day, it's an ulceration, and so many different secondary changes can happen within that ulcer, and it really depends on the time point of the ulceration. So if you really want to get an answer in a patient that has ulcers, you have to identify a lesion before it ulcerates and biopsy that, because that's going to give you more of the causative pathophysiology that could be leading to ulceration. And plus, at the end of the day, you're just going to have to go to your clinical data, your clinical scenario, your serologic and laboratory data to try to piece together exactly what is causing the ulceration clinically in the patient. So chronic leukocytoclastic vasculitis can be seen in granuloma faciale and erythema elevatum diutinum. Granuloma faciale typically occurs in middle-aged to older patients on the face as papules, nodules, plaques. It's chronic and the recurrence is frequent. This is the classic entity that you should remember that contains a Gren zone, which is lack of involvement of the very top part of the dermis. So you see this clear separation between the epidermis and the inflammation in the dermis. That's known as the Gren zone. You see dense cellular dermal infiltrate, including polymorphous mixed infiltrate. So eos, newts, plasma cells, mast cells, lymphocytes, everything's there. The vasculitis, in fact, may be very difficult to see or not seen at all because you have so many cells in the area. You can't make sense of any kind of perivascular pattern whatsoever. It's the Gren zone and that mixed inflammation on the face that's going to give you the diagnosis. Is DIF helpful? Well, you can have granular IgG and complement at the dermal epidermal junction and the vessels. It's not anything specific. I wouldn't rely on a DIF to make the diagnosis. Typically, it involves facial skin, such as the sebaceous follicles. You can see demodex mites, which often overlap with rosacea. So, of course, it's very common and sometimes difficult to rule out an evolving granuloma faciale and like a granulomatous rosacea or chronic rosacea. But the Gren zone is very helpful. If you do see LCV with eosinophils and onion skin fibrosis in chronic cases, you can think about it. Now, if you hear onion skin fibrosis, that's going to make you think about the other entity we're about to talk about, erythema elevatum diutinum. And it's unfortunately a misnomer, so you don't have granulomas on the actual pathology. It's just in the name. So here you see that Gren zone, which is that lack of involvement of the upper epidermis, that clean separation between the dermis and then the slightly lower inflammatory infiltrate in the dermis with perivascular lymphocytic inflammation composed of neutrophils, eosinophils, lymphocytes, histiocytes, mast cells. Here you see just an example of some of those eosinophils, some areas of Cutaneous, taken from Dr. Elston's textbook. Erythema elevatum diutinum is an uncommon disease. As I said, it's like the forgotten or usually forgotten vasculitis, but hopefully you won't forget it now after the lecture. It's a localized variant of LCV, forms papules, nodules, and plaques, often on the extensor surfaces of the joints, and it's symmetric. So the classic Kodachrome is going to show you dorsal hands with some nodules on it. The differential diagnosis should always include erythema elevatum diutinum. Often these patients have an IgA paraproteinemia. So as I just said, this is from Bologna. You see these nodules forming on the back of the hands. Of course, your interdifferential diagnosis, you would think of things like multicentric reticular histiocytosis. In part, panel B, you see this really nice nodule that's developed. And again, that's why I think most people forget it's a vasculitis, because they just see these nodules. They think it's some type of neoplastic process. And then here around the ear, of course, you might be thinking of something like relapsing polychondritis because it's affecting the ear, but it's actually an erythema elevatum diutinum. And remember, if you see something like this, you can think about an IgA paraproteinemia being affected. So in early lesions, you'll see LCV, abundant fibrin, mixed dense inflammation, granulation tissue, and scarring starts to happen in older lesions. So that onion skin fibrosis with, it actually does look like onions here in the late stage. You can even have areas that look like a sclerotic fibroma in your late stage of erythema elevatum diutinum. But in your early stages, that's where you've got most of the LCV and the mixed inflammation and the vasculitis process happening. And once that vasculitis is burned out, then you progress to this onion skin fibrosis in the late stage. Neutrophils are more common in erythema elevatum diutinum, and eosinophils are more common in granuloma facialis. So if you had to make the choice between these two, if you saw a lot more eosinophils in a grin zone, you can think about granuloma facialis. If you see more of a very dense inflammation with neutrophils and then maybe even a little bit of onion skinning fibrosis in some areas, you can think about erythema elevatum diutinum. And this is highly, highly testable. What are the associations with erythema elevatum diutinum? So you'll want to see, does the patient have an infection? Do they have HIV? Do they have strep? Do they have hepatitis B, tuberculosis, or syphilis? Again, vasculitis is due to a trigger. So you're not surprised at all that these are the same triggers as any other vasculitis that you would see. Rheumatic includes things like GPA, inflammatory bowel disease, celiac disease, relapsing polychondritis, SLE, and RA. So again, these associations make a ton of sense because they're usually antibody mediated, and you're gonna see some vasculitis in many of these processes. Malignancy, such as hematologic malignancy, I mentioned IgA paraproteinemia, myelodysplastic syndrome, myeloproliferative disorders in general. So here's a very high yield testable snapshot from Dr. Elston's book, showing that onion skin fibrosis and then those slit-like spaces in between the collagen that you can sometimes see in sclerotic fibromas. So there's this fibrosis happening concentrically around the vessels, which implies a vasculopathy as the underlying pathology. Here again, you see some more examples of the onion skin fibrosis. Here is another picture from Dr. Elston's textbook showing inflammatory nodules with fibrosis. And more examples of the onion skin fibrosis pattern with a mixed inflammation, including abundant neutrophils, leukocytosis, Cutaneous. And here's kind of where I mentioned that similarity with the sclerotic fibroma, the lamellar fibrosis here. So, and you can see areas of more burned out onion skin fibrosis or lamellar fibrosis in the same lesion of this kind of more inflamed area. So that should be given to you on an exam so you can make sense of it. Otherwise, if it's too busy and you can't pick out any architectural features, it may be difficult to call it erythema elevatum diagonum. But these are the high yield pictures you should know. And a pearl from Elston is that most drug-induced vasculitides present with a little 5 pattern. The exceptions include a big 5 pattern, which may be seen with montelukast, PTU, methimazole, hydralazine, and minocycline. Again, most patients on these medications do not experience vasculitis, but we have to think about drugs anytime we do get a vasculitis. Incidental vasculitis is not associated with immune complex disease. It occurs in ulcers and adjacent to suppurative folliculitis. As I mentioned, ulcers, again, it's a chicken or the egg question. You're definitely not going to be able to say it was caused by vasculitis if you have a full-blown ulceration. Neutrophilic dermatoses such as sweets as well, of course, that's a neutrophilic process. So as those neutrophils pour into the site of pathology, of course, they're going to end up causing vessel inflammation and destruction. So just to hammer it home, leukocytoclastic vasculitis is frequently seen as an incidental finding at the base of a chronic ulcer or adjacent to a focus of suppurative inflammation, and focal incidental LCV also occurs in sweets. Bowel bypass syndrome, also known as BADAS or bowel-associated dermatosis and arthritis syndrome, pyoderma gangrenosum, and neutrophilic dermatosis of the dorsal hands. There is an entity called pustular vasculitis where you have such a huge amount of neutrophilic inflammation and pustule formation, and you see actual vasculitis as well. To call something pustular vasculitis has been often probably overlapping clinically with many of these different syndromes, including neutrophilic dermatosis of the hands. However, there are some publications by Dr. Croson and Cynthia Magro that really kind of define pustular vasculitis. Here you can see in an area of an ulceration, you've got this fibrinous base here, and then you have inflammation below that. So when you have an ulceration and you've got such dense inflammation here with lots of neutrophils, it could be a variety of conditions that ultimately led to the ulcer formation. So you can't say which came first, unfortunately. You can see abundant neutrophils even within inside of the vessels, and incidental vasculitis, some areas of fibrin. And other entities where you see abundant neutrophils like this include things like Sweet syndrome and, of course, pyoderma gangrenosum, which has criteria published by the Delphi consensus that you can use to help make the diagnosis of pyoderma gangrenosum. But of course, when you have no other clear cause of what's going on to cause ulceration, and you do a biopsy and there's abundant neutrophilic inflammation, even undermining the normal dermis or the normal epidermis, then you can think about pyoderma gangrenosum. I do highly encourage you to look up the Delphi consensus on diagnosis of pyoderma gangrenosum. Sweet syndrome. So in a pure Sweet syndrome, a non-ulcerated lesion, if you go to a juicy, what we call juicy lesion, which has an intact epidermis on top of it, and you biopsy that, you should see marked papillary dermal edema, as well as nodular and diffuse infiltrates of neutrophils with karyorhexis, and focal LCV, which is common, but that's not the primary pathology. LCV is not the primary pathology from an immune-mediated standpoint. So this snapshot is classic for Sweet. So it shows abundant papillary dermal edema, an intact epidermis. This is not ulcerated. Yes, Sweets can lead to ulceration. So that's why it becomes difficult to biopsy an ulcer and say it was Sweets that's causing that. But if you biopsy something before it ulcerates and you see dense neutrophilic inflammation, abundant papillary dermal edema, then you're dealing with a neutrophilic dermatosis. Here you can see abundant neutrophils with areas of vessels that are generally intact in Sweets. Moving on to acute urticaria, superficial dermal vessels are filled with neutrophils, and your differential diagnosis for urticaria is actually normal skin, or your differential diagnosis for normal skin on histology includes urticaria because it can look very nondescript. You just find some marginating neutrophils in the vessels, as you can see here. So most of this biopsy looks pretty unrevealing on low power and on high power. This is from Dr. Elson's book. You find intravascular neutrophils, and that's about it. And maybe some mild edema in the dermis. And if they were thinking urticaria versus urticarial vasculitis clinically, you can rule out urticarial vasculitis. You don't have significant destruction around these vessels, but you do have intact neutrophils marginating within the vessels. And you can often find eosinophils around the area as well. So what do you see in late urticaria? Superficial vessels still contain neutrophils, diapedesis of neutrophils through the vessel wall, distinct absence of karyorrhexis and no fibrin in the vessels, no expansion of the vessel walls. Again, just maybe some eosinophils scattered around the vessels that contain interstitial neutrophils. Wells syndrome, also known as eosinophilic cellulitis. If you hear Wells syndrome or eosinophilic cellulitis, think of flame figures on pathology. These are flame figures here. They're basically collections of cells that release components of eosinophils and major basic protein. They resemble the center of what you see in a Schurg-Strauss granuloma. And what leads to this is recurrent, or what you typically see in Wells syndrome is recurrent erythematous plaques that demonstrate flame figures histologically. Some cases represent a distinct entity, but most represent exaggerated arthropod reactions. So basically just a superficial and deep perivascular inflammatory infiltrate, oftentimes containing abundant eosinophils that have degranulated and released major basic protein. That results in this mixture of heavily basophilic and eosinophilic collections around vessels, and some of them look like a flame on a fire that's just burning and extending upward. You can see here a better example of a flame figure from Dr. Elson's textbook. So just this very kind of a mix of basophilic and eosinophilic areas where the eosinophils have degranulated, and you get these strong areas of quote unquote flames developing within the dermis. Again, Wells syndrome versus exaggerated response to an arthropod. It's a little bit controversial if you can truly separate those two on histopathology alone, but clinical scenario is going to play a huge role. Here you see intact eosinophils, and then you see degranulated areas of eosinophils that have gone out into the interstitium and form this flame. Very beautiful pictures from Dr. Elson's textbook here. So what causes perivascular lymphoid infiltrate? So we're talking about vasculitis. You can't just assume everything's neutrophilic. So you can have perivascular lymphocytic inflammation, and that doesn't equate to the same things you see on LCD, like fibrinoid necrosis usually, or extravasated red blood cells. But what you often can see is perivascular lymphocytic inflammation, which is a super nonspecific inflammatory pattern in histology. That can happen after drug exposure. Like, you just have to get a good history. You might see some interface change, but it's usually with drug, you're going to see just very faint vacuolar interface, if any at all, and some perivascular inflammation. That's consistent with a morbilliform drug, and you don't even have to have eosinophils. Viral exanthems can also lead to just nonspecific perivascular lymphocytic inflammation. Again, history is key. You might see some mild interface or spongiotic change, some epidermal change. Gyrate erythemas, this is typically where you're going to see that coat sleeving effect of dense perivascular lymphocytic inflammation that leads to this gyrate erythema appearance clinically. You might see a little bit of spongiotic change as well. You can also get perivascular lymphocytic inflammation in a whole host of different disease types, including dermatophyte infections, id reactions, pigmented purpuric dermatoses. I will mention on id reaction that you can see perivascular or spongiotic change with or without eosinophils. So again, it's a very non-specific eruption that happens kind of away from the triggering site on the body, but you can see just general spongiotic inflammation. It doesn't have to have EOs. So on pigmented purpuric dermatoses, all types of pigmented purpura represent forms of chronic lymphocytic capillaritis. There are different variations. They include this thumbprint hemosiderosis with cayenne pepper spots. That's your Schomburg's disease. You can have annular telangiectatic purpura. That's known as Mayaki's purpura. You can have lichenoid purpura of Gougereau and Bloom, and eczematous purpura of Ducas and Capitanacus. You can also have lichen aureus. In all forms of the pigment purpuric dermatosis, an iron stain, which is also known as Pearl's stain or Prussian blue, ferrocyanide or Gomori iron, they can be used to demonstrate hemosiderin as opposed to melanins. So iron stain highlights hemosiderin and turns it blue. Lichen aureus is a localized form of pigment purpura related to an underlying incompetent perforator valve. In other entities where you see perivascular lymphocytic inflammation, polymorphous light eruption. So polymorphous light eruption, I tend to think, shares a lot in common with sweets in terms of the abundant superficial dermal papillary edema. But in contrast to sweets, it does not have neutrophils. It has lymphocytes. So basically, PMLE is going to show the same dermal papillary edema in most cases. You might find some melanin capping above keratinocytes, but you'll have superficial and deep lymphocytic inflammation. Connective tissue disease, of course, can lead to superficial and deep perivascular and periadnexal inflammation. Here's an example of pigmented purpuric dermatosis. All of the different subtypes typically look very similar in the respect of perivascular inflammation with foci of red blood cell extravasation. Again, postcapillary venules are small caliber vessels, so it's just this kind of capillaritis that's even smaller. It's lymphocytes around the capillary that you're going to see. And different subtypes, like the ones that have more of a lichenoid dermatitis, lichenoid purpura of Gougereau and Bloom, you might see more of a denser lichenoid areas. You might see more of a hypergranulosis and hyperorthokeratosis above here. If you had an eczematous subtype, you might see more of the spongiotic change here. And that would also correlate with the different subtypes. Otherwise, it's just going to be signed out as a capillaritis consistent with pigmented purpuric dermatosis. Oftentimes, you'll get the clinical rule out LCV versus pigmented purpuric dermatosis. This is not LCV, so it's pigmented purpuric dermatosis. Here's a beautiful example of the coat sleeving pattern from Dr. Elson's textbook. You can see erythema annulare centrifugum often has this really nice medium coat sleeving lymphocytic, basically a sleeve around the vessel. And so a common rule out I get clinically is rule out granuloma annulare versus erythema annulare centrifugum. And it's always nice when I look at the slide and I see there's absolutely nothing that looks like granuloma annulare, and it looks exactly like erythema annulare centrifugum. So it's nice to be able to confirm the diagnosis when you see this. Polymorphous light eruption, here you can see that abundant superficial papillary dermal edema, superficial and deep. You can't see the deep one here, but superficial and deep perivascular lymphocytic inflammation. And if you go to the epidermis, you'll see a lot of melanin on top of the melanocytes forming a cap-like structure. So that's your photoadaptive response and the melanin capping that you'll want to see in polymorphous light eruption. Now, polymorphous light eruption is not only polymorphous clinically, so you can have lesions in various stages, but also histopathologically. So every diagnosis of PMLE may not have the beautiful classic abundant superficial papillary dermal edema. If you get that, then that's perfect. And you'll want to probably see something like that if you're going to be definitive. But if clinically the suspicion is PMLE and you've got some photoadaptive response up here and you've got some superficial and deep perivascular lymphocytic inflammation, you can say you can't rule out PMLE. It definitely could be PMLE still. You can see spongiosis in the dermis as well, but you may not always see spongiosis. And so what ends up happening here is sometimes you can have photoallergic or photoeczematous reactions. And so separating out PMLE versus a photoallergic can be very difficult because you could have spongiosis in both entities. And in my opinion, if you see abundant eosinophils and you see photoadaptive response and spongiotic change without this amount of papillary dermal edema, then I would favor more of a photoallergic response as opposed to a classic PMLE. And if I didn't see a ton of eosinophils here, this would be more of a classic PMLE. So I'm hoping that I'm giving you an appreciation for how difficult it can be on real world samples to separate out a lot of the photodistributed dermatoses. So if someone says rule out PMLE versus photoallergic, we would be looking for some subtle different findings. So eosinophils, I would expect to see more in photoallergic. Another important point is that in classic connective tissue disease, you typically are not going to see abundant amounts of eosinophils. So if someone asks me to rule out, there's a photo-distributed process and they want me to rule out lupus, I might see some interface change, but I see abundant eosinophils. I cannot say that that's a classic because usually you will not see abundant eosinophils in classic autoimmune connective tissue. Now, tumid lupus also shows a nice perivascular and periannexal lymphocytic inflammation and periecrine with abundant mucin within the epidermis or within the dermis. Usually the epidermis is not heavily involved in tumid lupus and the basement membrane is left intact. So that's why you don't get a great destruction of the basement membrane in tumid lupus, and it will not ultimately end up in a scarring process. As opposed to discoid lupus, where you do have destruction of the basement membrane and you often get scarring. So with tumid lupus, you heal often without scarring. But when the lesion is in its most active state, you have perivascular lymphocytic inflammation with abundant mucin. So there are some true lymphoid vasculitides where you have lymphocytic inflammation that's leading to vessel damage. And that's in diseases such as Dagos disease, also known as malignant atrophic papulosis. You can see this in insect bites, arthropod assault, perniosis, Behçet's, and atrophy blanche. I will say that in Behçet's, you can also find lymphocytic inflammation as well, or neutrophilic and lymphocytic inflammation mixed, and that's actually quite common. Dagos disease or malignant atrophic papulosis is a rare systemic disorder with poor prognosis. It may be related to lupus. You have crops of papules sparing the palm, soles, face, and scalp. So it's sparing those areas, but everywhere else can be involved. Papules develop this central depressed porcelain white appearance. They often have intestinal involvement, and these patients can actually die of GI perforation in Dagos disease. So here's the pathology from Dr. Elson's textbook where you see this atrophic, this is corresponding to that atrophic porcelain white center. So you can see it loses its kind of reedy ridge architecture. It's flattened in. This is the atrophic papule of malignant atrophic papulosis or Dagos disease. If you saw an image like this and they asked you what was the most likely way the patient was going to die, it's going to be GI perforation. So again, red papules with ivory white atrophic centers, valve perforation and stroke, unfortunately, can happen. Associated with this disease, you'll see wedge-shaped superficial and deep perivascular lymphoid inflammation with vascular damage in the most active state. But over time, you get that central epidermal depression with atrophy. You can see avascular necrosis of dermal structures as well. So where are the follicles? Where are the eccrine glands? They're gone, right? And marked dermal mucinosis, so a lot more mucin in here as well. Here's an example of beautiful stringy blue material within the dermis. So this is your mucin. What do you see in insect bites? So insect bites or arthropod assaults result in dense wedge-shaped perivascular lymphocytic inflammation, plus or minus edema, plus tons of eosinophils. So if you see a dense wedge-shaped inflammation with lots of eosinophils, you cannot rule out an arthropod assault. Now you can think of other entities such as drug reactions, and you can think of things like evolving bullous pemphigoid with that many eosinophils. There's so many other things you can think about. You can think about granulomatosis with polyangiitis even, but you can't rule out an insect bite unless you have the clinical scenario. Variably, atypical looking lymphocytes, focal leukocytoclastic vasculitis may be present. Here you see some abundant papillary dermal edema and a bullous arthropod assault. So again, if you had this subepidermal bulla with abundant eosinophils, it's going to be hard to say that that's not bullous pemphigoid, right? So if this patient had a ton of bulla like that, and they couldn't tell you, oh, they got bit by a bunch of bugs, and you did a DIF, the DIF should be negative for IgG and C3, so arguing against a bullous pemphigoid. But just based on H&E alone, this would be difficult to say it's not bullous pemphigoid. However, usually in bullous pemphigoid, you have a lot more eosinophils up here in the cavity, and you don't have as much deep eosinophilic wedge-shaped inflammation as in a arthropod assault. Here you see some perivascular inflammation with neutrophils and eosinophils in an arthropod assault, abundant eosinophils everywhere. Perniosis is a diagnosis of acral skin. So if you've got areas of vasculitis, lymphoid vasculitis happening on acral skin, such as the toes or the feet, the fingers and the hands, you can think about perniosis. You're going to see superficial and deep perivascular lymphocytic inflammation. And on histology, you'll find fluffy edema and expansion of vessel walls without fibrin. So you can see the clinical presentation of perniosis with this dusky purple to almost grayish plaque on acral skin, particularly on the toes. We did see a bunch of this with COVID infections in young pediatric patients that came in. They would have this perniosis-like presentation that was occurring in the setting of their infection. And what ends up happening is this abundant formation of superficial papillary dermal edema and perivascular lymphoid inflammation. So does this look familiar to you? You might be thinking, well, this looks exactly like the polymorphous light eruption that you just showed. So polymorphous light eruption and perniosis look very, very similar, if not identical, on histology. If you know you're on acral skin, then you can think about perniosis. Here you see this fluffy edema that occurs around the vessels in perniosis as well. Now, we did talk about a lot about vasculitis and briefly, talked about vasculopathy. So vasculopathy is the occlusion of vessels presenting as livedo reticularis or necrosis of tissue. So why necrosis? Think about it. If you have vasculopathy, you have impaired blood flow in your vessels. You're lacking oxygen to the downstream tissues, you're going to get necrosis. If you biopsy something that's necrotic or ulcerated, and you ask the pathologist to rule out vasculopathy, that's nearly impossible to do because the ischemia and the necrosis has already destroyed so much tissue, it's going to be hard. You have to get an area that's not quite fully necrotic or ulcerated. You want to try to find deeper tissue, maybe within the ulcer or prior to ulceration. But if you've got a full-blown ulcer, then it's going to be difficult to say. Again, you can have secondary leukocytoclastic vasculitis happening in an ulcer that was ultimately caused by vasculopathy. So vasculopathy leading to an ulcer, you see LCV and the ulcer, it doesn't mean LCV caused it. It means that the LCV is there because of the acute neutrophilic inflammation that's happening after the ulceration to try to heal that ulcer. So if you biopsy a non-ulcerated area of livedo reticularis or a purpuric patch or some type of intact epidermal skin that has underlying retiform purpura, you might be able to pick up on vasculopathy, where it's clear that you've got intraluminal thrombosis, but you don't have any vasculitis, and that's going to help you make the diagnosis more than anything. clinical scenario, clinical presentation, it all comes into play along with supporting labs. So if you get cryoglobulinemia, or you know that they just had a recent COVID-19 infection, or there's other labs that are associated with coagulopathy. Cryoglobulins are just one, but you can have even homocysteine dysmetabolism can lead to uh, vasculopathy. Factor V Leiden can lead to vasculopathy. Proteinase 3, uh, uh, protein CNS deficiency, certain medications, right? Certain lymphoproliferative disorders, Waldenstrom's macroglobulinemia. I mean, there's so many things that can lead to vasculopathy. And so being able to identify a pure sample that has true intraluminal thrombosis before ulceration is going to be key. Other entities such as segmental hyalinizing vasculopathy or atrophy blanche will present as lower leg scarring plaques over time, but in the initial phases, you can see acute thrombosis and vasculopathy. So let's talk about cholesterol emboli. Patients with atherosclerosis often happens in anticoagulated states or post-cath procedures. You'll see mottled or infarcted skin lesions. You can see livedo reticularis with reactive hyperemia, and visceral infarcts can occur in the renal tissue. So here you see an example clinically of cholesterol emboli. Patients got a break off of the cholesterol deposits that spread down distally and cause local vasculopathy and ischemia. More examples. On pathology, you might get lucky and see crystals in the deep arterioles here. So you can see this nice crystal shaped formation and cholesterol emboli. Again, higher power from Dr. Elson's textbook. Very nice crystal clefts. So we've talked about a lot in this lecture. We've covered a lot of ground. But in summary, I would like to bring your attention to this cartoon again, which shows you how to organize the large vessel vasculitis, such as Takayasu's arteritis and giant cell arteritis, the medium vessel vasculitis, including polyarteritis nodosa and Kawasaki disease, the ANCA-associated small vessel vasculitis, including microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis, your immune complex small vessel vasculitides, including IgA vasculitis or Henoch-Schönlein purpura, cryoglobulinemic vasculitis, and remember that's type 2 and 3 cryoglobulinemia, and hypocomplementemic urticarial vasculitis, where patients have low levels of complement but still have vasculitis that looks like urticaria clinically. And these patients are at high risk for renal disease, and anti-glomerular basement membrane disease, which attacks smaller capillaries. Here is that classic picture you should have in your mind of the fibrinoid necrosis around vessels, but you cannot always expect to see that. What you're going to look for more is perivascular neutrophilic inflammation with abundant leukocytoclasis. Thank you for your attention.